Good morning, Assalamu alaikum. Today, our session is basically the continuation of the previous series of RCC, and it will center around the management of the localized RCC. So, everyone is please appreciated to speak up if possible. Yes, Maria.
Assalamu alaikum. I'm Dr. Mariam. Today we are going to present the localized RCC management, and this session will be moderated by Dr. Shiri. And as she has already discussed, that this is the continuation of our previous lecture. So the basic objectives that we are going to discuss today are the active surveillance and the surgical resection of the masses, including the radical nephrectomy and the partial nephrectomy. So a little bit about the introduction of today's lecture. So over the last 20 decades, the incidence of the RCC has been greatly increased globally worldwide due to the advances in the cross-sectional imaging and because of the increased frequency of the incidental diagnosis of the small renal masses. So by definition, what are the small renal masses? So they are defined as the incidentally image detected contrast enhanced renal tumors which are less than or equal to 4 centimeter in diameter. They correspond to the stage T1A RCC, and the characteristics are that they are indolent in nature. They have a slow growth rates of 1 to 3 per year, and they have a low risk of the metastasis. But despite their low risk of the metastasis and the slow growth rate, the treatment of the small renal mass should be done because the 25% of the small renal masses, they are the benign lesions with the goal of preserving renal function as far as possible and avoiding the risk for the over treatment should be done in these cases. So the second modality, the second moiety is the large renal masses. So large renal masses are the solid localized renal masses of greater than 4 centimeter in size, and the characteristics are that they usually corresponding to the T1B and T2 RCC, and they have a rapid growth rate as compared to the small renal masses of 4 to 8 per year, and they have a higher risk of the metastasis of 4 to 6 in contrast to the small renal masses.
Basically, there is this entity, small and large renal masses, are mentioned in the literature, but they are not specified with regards to the management. For management, you will always go for TNM staging. But yes, the literature do mention these definitions of small and large renal masses. You should also know this. Yes.
So this is the brief diagrammatic representation of this small renal mass and the large renal mass that I have already mentioned before. That is small renal masses of T1A less than 4 centimeter limited to the kidney, and large renal masses of T1B and T2 stages with 4 to 7 centimeter and greater than 7 centimeter but limited to the kidney. And the treatment modalities that can be done in these cases are the active surveillance, focal therapy, partial nephrectomy, or the total nephrectomy that we are going to discuss later on. So what is the active surveillance? So active surveillance is defined as the initial management, including the monitoring of the renal tumor size by serial imaging with a delayed treatment in case of the progression, and is now considered an option in the treatment of the localized renal tumors. And this active surveillance term should not be synonymous with the observation or the watch and wait period, because it should be differentiated from the watchful waiting, because in case of the watchful waiting, the routine imaging is not done, and the curative and the active treatment in case of the watchful period only to be done when the until unless the symptoms appear. So it entails a highly individualized follow-up strategy involving the serial imaging for evaluating the growth of the masses, and the shared decision making is an essential component of the process between the urologist and the radiologist regarding the modality of the choice for the monitoring of the patient. For example, cross-sectional versus ultrasound, and the timing, that is 3 monthly versus 6 months with each imaging result. And notably, delayed intervention does not compromise the outcomes with this strategy. So here are the indications for the active surveillance according to the different guidelines: EUA guidelines, AUA guidelines, and the ASCO guidelines. So according to the EUA guidelines, active surveillance should be performed in the patients who are older ones, who had worse ECOG scores, and definitely the higher ASA scores as well. Those who have the more comorbidities, those who have the smaller tumors that can be followed on the basis of the active surveillance, for which the surgical modality cannot be preferred, and more often had multiple and bilateral lesions that is involving the bilateral kidneys. Whereas the AUA guidelines suggest that those patients with the renal masses are suspicious of the cancer, especially those smaller than 2 centimeter, and it should be priority when the anticipated risk of the intervention or competing risk of the death outweigh the potential oncological benefits of the active treatment. Means the risk of the intervention is more, so that's why we will go for the active surveillance in those cases. And when the results of the risk versus benefit analysis of the treatment are equivocal and the patient elects to undergo for the active surveillance after counseling. According to the ASCO guidelines, the absolute indications are absolute indication is when there is high risk for the anesthesia, as we have already discussed, based on the comorbidities and the high RACE score of the patient, and intervention or life expectancy of less than 5 years. Whereas there are certain relative indications in which there is a significant risk of the renal dysfunction of ESRD, that is end-stage renal disease, when the eGFR becomes less than 15%, and small rare masses of less than 1 centimeter, and when there is a life expectancy of less than 10 years.
So more or less almost same indication as per each guidelines. Basically old, frail patient, poor performance status, multiple comorbidities, have a high risk of surgeries. So active surveillance or observant waiting, right? Observant waiting,
Yes.
that is another word, should be reserved for these patients.
With the
But
imaging.
again, it's very cumbersome for some patients because the repeated imaging has to be done time and again.
Yes.
So this is one of the hazard for which a patient usually do not accept this follow-up.
So the contraindications of this active surveillance: renal masses with the irregular borders, again when there is a suspicion of the possible malignancy; non-localized renal tumors that is locally, lymphatically, or hematogenetically disseminated, and when the oncologic benefits of the intervention outweigh the risk of the treatment and competing risk of the death. This is the vice versa of that we have previously discussed. And when the patient refuses to be included in the active surveillance group. So, role of the renal tumor biopsy before the active surveillance. This slide has been taken from the EAU guidelines. And this states that histological characterization of the small renal masses by renal tumor biopsy is useful to select the tumors at lower risk of the progression based on the grade and the histotype, which can be safely managed with the active surveillance. Pathology can also help to tailor the surveillance imaging schedules. In the largest cohort of the biopsy proven small sporadic RCCs followed with the active surveillance, a significant difference in the growth and the progression among different RCC subtypes was observed. And clear cell RCC small renal masses grow faster than the papillary type 1 small renal masses. That is the rate of 0.25 for clear cell carcinoma and 0.02 for the papillary type 1 variant as an average respectively per year. Again, there is a consensus between the different guidelines, but the recent guidelines suggest that the one should go for the renal tumor biopsy before going for the ablative techniques and before going for the active surveillance of the patient. So once the patient has been decided by the primary team that this patient should be kept on the active surveillance, then this is the algorithm or the active surveillance protocol. So once the patient has been decided for the active surveillance, then the strict follow-up imaging protocol should be made. That is, during the first 2 to 3 years, the patient should be followed every 3 to 6 monthly on the basis of the contrast-enhanced CT scan imaging, because the risk of the metastasis is increased in the during the first 2 to 3 years, and also the tumor growth rate will be undetermined during the first 2 to 3 years. So that is why the repeated follow-up is necessary. And then after 2 to 3 years, once the tumor size becomes stabilized, then we can follow the patient every 12 monthly, again based on the cross-sectional versus ultrasound imaging. And then up to 5 years, when the patient followed to us on the basis of the stable tumor size, then after 5 years we have 3 options. If the tumor is still stable size, is of a stable size, then we can discontinue the active surveillance, or we can space the follow-up period to the longer duration. And if the tumor is slow growing based on the progressive tumor growth rate period, then we can continue the imaging yearly. And if there is a progression in the tumor growth rate that is greater than 0.5 centimeter per year, then we can evaluate this patient while after discussing this patient in the MDTs, that is the multidisciplinary committees. So, how the tumor growth rate should be calculated. So the small renal masses, they are calculated on the basis of the maximum tumor diameter that we can be taken from the on the basis of the CT scan imaging. So maximum tumor diameters used to measure the small mirror masses, and the other the parameters are the cross-sectional area and the volumetric assessments for the linear growth rate measurement. So there's a formula here in which we have to divide the difference between the two maximum tumor diameter into 2 points and the number of the months passed, and then multiply by 12. So by this manner, you can have the linear growth rate of any small mirror mass of the particular patient. So in this image, this is the coronal CT scan view of the image of the patient who was previously kept on the surveillance. And in the image A, we can see that this is a small mirror mass located on the lower pole of the kidney. And it has the maximum tumor diameter of 2.5 centimeter that is mentioned over here. And again, this patient was followed after a period of 3 years that made him 36 months in between these 3 years. So again, this patient was followed, and this time this this maximum tumor diameter was again came out to be as 2.5 centimeter. So now dividing these two, dividing the difference of these two, 2.5 minus 2.5 divided by the number of the months passed, that is 36, into the 12 will came out to be result as the 0. So this means that there is a stable size of the tumor size of the patient. So after that, we will decide again that if the tumor size is stable, then we can discontinue the active surveillance of the patient after discussing it in the MDTs. So definition of the progression, again, in other words, according to the ASCO guidelines and the AUA guidelines, according to the ASCO guidelines, the tumor size, when the tumor size becomes greater than 4 centimeter and when the growth rate is greater than 0.5 centimeter per year, then it comes under the category of progression, and it becomes out from the active surveillance. And when according to AUA guidelines, when the growth rate becomes greater than 0.5 centimeter and when the tumor size becomes greater than 3 centimeter and when the CT scan imaging on the surveillance showed the metastatic disease, then it comes under the category of progression.
Active participation from R5, especially who are appearing for exams, will be appreciated. कुछ भी बोल दो, गलत बोल दो, सही बोल दो, कोई भंड मार दो, मतलब बोलो ताकि वहां पर आप लोग ना एक्टिव हो सको. ये ऐसे पढ़ाने का कोई फायदा नहीं है.
जिनको पहले ट्यूमर प्रोग्रेशन का पता था ऐसे कि मुझे नहीं मालूम पहले और क्वेश्चन करना मुझे या हमें मालूम था कि व्हाट इज द हमसे एक समझते कि 1.1 सेंटीमीटर से 1.3 सेंटीमीटर हो गया तो ट्यूमर साइज इंक्रीज हो गई. तो आप लोगों का भी यही कंसेप्ट था कि ये वाला कंसेप्ट था जो इस व्यक्ति ने बताया. कुछ नहीं कर रहे तो उसको अप्रिशिएट कर दो कि
We usually say कि भाई progress हो रहा है, but this is a very good presentation or slide showing how the tumor progresses and what should be the criteria of switching a patient from active surveillance to aggressive therapy.
So coming to our next slide, multifocal small renal masses and their active surveillance. So first of all, we should know that what is the multifocality. So it is defined as the presence of more than one tumor, which can be unilateral or bilateral in small renal masses. So in the multifocal small renal masses, they can be synchronous, that is present at the same time, or the metachronous, that present at the different times, and they are considered synchronous if appearing within less than 6 months of the imaging. And again, there is a very limited literature present about the clinical behavior of these multifocal small renal masses and their management. Bilateral renal tumors have been observed in 90% of the patients with multifocal tumors, and the most frequent histological RCC variant associated with the multifocality is the papillary subtype, but any histologic RCC can be multifocal. So multifocal renal tumors can be of two types, either sporadic or associated with the genetic syndromes. So the management of the multifocal renal tumors with the genetic predisposition is even more challenging, and at present there are no basic urological or the oncological consensus present regarding the active surveillance of these multifocal small renal masses. So again, this is the this is the representation of the management of the brief representation of the management of the multifocal renal masses, in which the genetic syndromes are written over here, and the associated renal tumors associated with these syndromes are written over here. So in case of the VHL syndrome, hereditary papillary RCC, Bird-Hawk syndrome, tuberous sclerosis complex, follow-up protocol is up to 3 centimeter. After that, you will have to go for the surgical intervention. And in case of the hereditary leiomyomatosis, renal cell carcinoma, succinate dehydrogenase B deficiency, BRCA1 associated protein 1 RCC, and MITF predisposed RCC, surgery is always recommended.
So again, the same thing of preactive surveillance. Small renal masses, old, fragile patients, multiple comorbidities, poor performance status, or as per patient's wish, the small renal masses can be managed by active surveillance. Okay. Regarding genetic study, one thing that has been included in our Campbell in one of the flow chart is a genetic counseling. It's very important these days, especially on the international aspects. Those patients who presents with the multifocal and the bilateral renal masses, and specifically those young patients who present with the renal masses in the early age, their genetic counseling is to be done for the study of their siblings as well, which is very common in developed areas of the world, but it's not very much active in the developing countries like ours. So this is also included, the genetic counseling for those patients who have been diagnosed with the recent RCC under 46 years. Okay.
इन्होंने BRCA1 के बारे में लिखा हुआ था, इसके बारे में किसी को कुछ मालूम है?
कौन से ट्यूमर में होता है, जीएस में पढ़ते हैं, क्यों होता है? यस,
तो वो यहाँ से ये ब्रेस्ट कैंसर नहीं पढ़ा रही, इसने क्यों डिसाइड किया? BRCA1 जीन जो है या इसी का कैंसर
Preventive.
कैंसर प्रोमोटिंग जीन इसने बोला आप बताओ, वेरी गुड,
ट्यूमर सप्रेस।
ट्यूमर प्रिवेंटिंग जीन, ये तो ब्रेस्ट सर्जरी नहीं पढ़ा है, ये क्यों बता रही है? आप बोलो, ऐसे ही बात ना उठाओ, धड़ से बोलते हैं।
Because BRCA genes are associated, it's a tumor protector of a genome kind of a gene. So when it is mutated, so it gives rise to a lot of cancers. Like even in prostate cancer, if patient has BRCA mutations, that suggest an aggressive course.
Positive, manipulative, or any suspected gene involvement in PhD, so people used to go for
BRCA screening.
mutation, not the BRCA1 that leads to malignancy. It is the BRCA1 mutation. It means the protective field is gone, and your helmet is gone, your seat belt is gone, and now you are going for this type of correction. And again, this is relatively a new concept. जब हम कहीं जगह एक जगह एग्जाम देने गया था, तो उनको बहुत सरसरी चीजें मालूम। हम ये जानते हैं कि जब आपके पास इतना अच्छा एक फोरम मौजूद है, आपका एक या एसोसिएट खड़ा होकर आपको गाइड करने को तैयार है, तो आपका ये टॉपिक आज कंप्लीट हो जाना चाहिए फॉर नेक्स्ट 5 इयर्स के बाद। अब आपने स्मॉल लीगल मैसेज की ही किताब से नहीं पढ़ रहे, आपने स्मॉल लीगल मैसेज में कोई डिस्कशन नहीं करना है, सबसे पहले ये टॉपिक पता चल जाता है। अगर आप सिर्फ 1 घंटा रोज कभी दे दें, ओपीडी के बाद, टेंडर के बाद, लंच टाइम में आकर फिर डिस्कस करने, एक ग्रुप बनाने के आगे लड़की का बम्बार्डमेंट करनी है, तो मेरा भी जाता है बम्बार्डमेंट, इससे अच्छा फोरम नहीं मिल सकता है, यकीन करें, जबकि आपको तमाम इतनी आसानी से तो नहीं निकाला होगा था, आपके पास मेहनत की होगी, पता नहीं कहाँ से उसने चीजों को पिक किया होगा। फिर आपका काम है कि इससे मैक्सिमम गेन करें, मैक्सिमम एब्जॉर्ब करें।
Now moving towards the surgical management of the localized RCC. So we will be discussing more about the partial nephrectomy. So anyone can have any idea or tell us about the partial nephrectomy and the basic definitions?
एनीथिंग, एनी कॉन्सेप्ट, कोई हाइपरफिल्ट्रेशन का कॉन्सेप्ट, कुछ भी एक्टिवली पार्टिसिपेट करें। आप सब देखते हैं, आप सब स्क्रब होते हैं। यस, एंड व्हाट कैन बी द इंडिकेशंस? रफ इंडिकेशन, वन, एटलीस्ट 1 or 2. यस, दोनों एक जैसा ही बोल रहे हैं। यस,
बताना चाह रहे हैं
नाजिश जी, नाजिश
डॉक्टर नसीम बता रहे हैं मैडम।
अच्छा अच्छा, कौन किसका नाम?
पार्शियल नेफ्रेक्टमी की इंडिकेशन एक किडनी के ट्यूमर का size less than 7 centimeter हो, and the second if the tumor is bilateral, and the third if the patient is having a low GFR, and the third if the patient is having proteinuria. So these are some indication of partial nephrectomy.
Fair enough, good. At least you guys know indications of partial nephrectomy. Yes, sir.
एक सवाल ये है कि how many times we go for a GFR before make a planning for partial nephrectomy? करवाइए कभी किसी की GFR?
24 hour
24 hours, सर हम 24 hour urine for creatinine clearance होता है.
24 hour creatinine
इसका मतलब है कि जरूरी नहीं है कि bilateral disease हो. You may have a normal serum creatinine, but if the patient is hypertensive or a diabetes, so that patient may have a low GFR, irrespective the creatinine is
Yes.
And literature also, sorry sir, and literature also states that more than 50% of patients who present with the tumor at the time in the clinic at the time of initial presentation do have eGFR less than 60 mils per minute for a one reason or so. So taking into consideration this eGFR before operation is very necessary.
So again, as it has been told by the audience that it is a nephron sparing surgery and becoming the optimal choice because of its advantage in preserving the renal function, and just a little bit from the history that it has become the gold standard for T1 RCC since 2006, and the standard surgical procedure should follow a route of excising at least 1 centimeter safety margin exterior to the tumor to ensure a true negative margin and to decrease the risk of the local recurrence. Indications, again, as already mentioned, that the indications are divided into the absolute, relative, and elective. Absolute are the single kidney bilateral renal tumor, severe renal failure, and the relative indications are the abnormal contralateral kidney. That is, again, as mentioned before, that induced due to the diabetic changes, due to the hypertensive changes, the nephropathy induced, having the stone disease, nephrolithiasis, or previous history of any trauma. Metabolic disease associated with the renal failure, genetic syndrome with the tumor multifocality. Again, we have discussed this before. That is a VHL syndrome. Elective when the tumor is less than 4 centimeter in young and healthy patients. Peripherally located tumor and the tumor greater than 4 centimeter but limited at 7 centimeter. That is less than 7 centimeter. And again, localized so that we can remove it. Contraindications are the absolute contraindications are when there is a metastatic or locally advanced disease, insufficient volume of the remaining parenchyma, renal vein thrombosis.
What percentage of a kidney should remain at the end of partial nephrectomy? Means how much percentage should be retained for a kidney if we are doing partial nephrectomy on it for it to be functional? 20 to 30%, rough estimate.
30.
Yes.
Uncorrected bleeding disorder, that is coagulopathies, non-reversible anticoagulation. Relative are the significant cardiopulmonary compromise and tumor encasement of the renal pedicle and diffuse tumor invasion of the central collecting system. So this is the renal nephrometry score, which is a very important component before going for the partial nephrectomy, and it is the score which we all are familiar with. So by definition, it is an objective method that can help in making the decision regarding the surgical resection of the organ confined localized RCC. So this score not only provides a risk assessment to us, but also predicts the possible surgical difficulties or the complications that one can have during the surgery while doing the partial nephrectomy. So this renal nephrometry score has 5 components, that is the radius, exophytic or endophytic properties based on the CT scan imaging. Based on the CT scan imaging, and nearness of the tumor to the collecting system or the sinus, anterior or posteriorly location relative to the polar lines. And each category has 1, 2, 3 points, except the anterior and the posteriorly located because it has no points and the mass assigned as a description of the AP or X. So based on this, it has 3 categories: low risk, moderate, and the high risk. The low risk one who falls between 4 to 6 points, and moderate is between 7 to 9, and high is between 10 to 12. And again, it gives us the risk stratification and tells us about the possible surgical difficulties that we are going to hamper during the partial nephrectomy. So techniques for the partial nephrectomy: open, laparoscopic, and the robotic assisted partial nephrectomy. So for the open partial nephrectomy, everyone knows that the position should be the patient should be positioned laterally with the ipsilateral side facing upwards, and the contralateral flank should be facing over the break of the table, and the kidney should be approached typically extraperitoneally through a flank incision, typically through the 10th or the 11th intercostal spaces. And once the retroperitoneal space has been approached, insert a self-retaining retractor, dissect the perineal fat off from the kidney, but not over the tumor. Perineal fat should be left intact over the tumor. And then isolate the renal pedicles sufficiently for the safe application of the vascular clamps. And then, as you can see in this image, control the bleeding, control the vessels with the help of these vessel loops. Then in the second image, you can see that there is a clamp applied over here over the renal artery. So the clamp application should be done over the renal artery, and the ischemia time point should be noted. And then kidney should be wrapped around with a sheet or the plastic bag containing the ice slush. Only if the anticipated ischemia time is supposed to be greater than 20 minutes, then it should be done. Our maximum try is to keep the ischemia time as short as possible. For the warm ischemia, it should be less than 20 minutes, and for the cold ischemia, it should be less than 35 minutes. Next step is incise the renal tumor capsule 5 mm peripheral to the tumor with the help of the electrocautery circumferentially, and then with the combination of the blunt and the sharp dissections, excise the whole of the tumor along with the small rim of the normal parenchyma along with this mass. And then once the mass has been excised, then it should be sent for the frozen section. So after sending the specimen for the frozen section, check the excise size for any bleeding, any sort of the bleeding, and control the bleeding vessels with the help of the figure of 8 sutures with the help of the bipolar cautery, and also to look for any collecting system injury. If there's any collecting system injury, if there is any doubt or the suspicious of the pelvic calyceal system injury, then we can check it by injecting the 10 ml diluted indigo carmine into the PCS by occluding the ureter, so that we can check the leak of the pelvic calyceal system, and if there is any leak, then we can repair the collecting system with the help of the 4050 absorbable sutures. After that, we are going to
Yes, any discussion, Mariam, first about a partial nephrectomy? आप लोग सब देखते हैं, कुछ डिस्कस करना हो, कोई ऐसी चीज पूछनी हो? जी यमुना.
न्यूक्लिएट किया और उस वक्त आपको लगे कि इसका जो है वो पेल्विस इन्वॉल्व है कलेक्टिंग
First of all, what is the difference between enucleation and partial nephrectomy?
इन्यूक्लिएशन में जो है वो आप सिर्फ ट्यूमर को जैसे सेबेशियस सिस्ट निकालते हुए द मार्जिन आप उसको निकालते हो, पार्शियल
What should be the thing that should be seen in enucleation but not partial nephrectomy? This is a very good thing. आपने बहुत अच्छी बात बोली यहाँ पे enucleation का.
arterial supply.
It's basically what the basic difference between enucleation and partial nephrectomy is that in enucleation the dissection is done around the pseudocapsule of their tumor.
Yes.
Surgeon usually try to avoid the rim of a healthy cortex with it. Okay. So this is a concept behind enucleation, and in the concept behind partial nephrectomy, the entire tumor in toto has to be taken out along with a relative margin of 2 to 3 to 4 millimeter, depending upon the surgeon preferences, surgeon choices, and the conditions of that kidney. So this is one of the basic differences, and the literature states that the localized tumor and a seedling are more in enucleation rather than partial nephrectomy. So enucleation is of little benefit, but again, some are having much expertise to do enucleation without leaving any residual tumor behind. So yes, Dr. Yumna, what is your question now?
क्वेश्चन ये है कि अगर हमने रिलेटिव कॉन्ट्राइंडिकेशन में भी जस्ट लर्न के कलेक्टिव सिस्टम की इन्वॉल्वमेंट जो है वो रिलेटिव कॉन्ट्राइंडिकेशन है, तो अगर आप कर रहे हैं पार्शियल नेफ्रेक्टमी और अगर आपका जो है वो पेल्विस इन्वॉल्वड है, कैलिसेस इन्वॉल्वड है, तो शुड बी अबैंडन पार्शियल, क्योंकि हम तो यहाँ पे करते हैं और उसके बाद उस एरिया को निकाल के अपने कलेक्टिंग सिस्टम को जो है वो रिपेयर कर लेते हैं.
No, it's not an absolute contraindication. It's a relative indication.
आरसीसी में pelvic calyceal system involve होता है?
नॉर्मली नहीं होता, लेकिन होता है
ये होना चाहिए.
T3
तो
में.
देखिए वो तो एक प्रेशर इफेक्ट है, उसने पेनिट्रेट किया है, लेकिन क्लासिकली जब आप पेल्विक एलिसियल इन्वॉल्वमेंट ऑफ मैलिग्नेंसी कहते हैं तो यू हैव टू और यू शुड चेक योर इनिशियल डायग्नोसिस अगेन कि आप टीसीसी को ट्रीट कर रहे हैं कि आरसीसी को ट्रीट कर रहे हैं. और अगर आप T3 की बात कर रही हैं तो फिर आप पार्शियल की, यहाँ तो उन्होंने पहले बता दिया कि अपर लिमिट जो है इस क्वारी 7 सेंटीमीटर. तो अगर 7 सेंटीमीटर से अंदर की बात कर रहे हैं तो हम T3 पे तो नहीं जाएंगे ना. तो हम तो बात कर रहे हैं, और अगर उसके बावजूद भी आपका एंडोफिटिक कंपोनेंट है, आपने ऑपरेट किया और यू वांट टू बी मोर सेफ, और पार्शियल का मकसद ही यही है कि आप लंपेक्टमी नहीं कर रहे. लंप में तो सिर्फ लंप निकलता है, इसका मतलब है कि आप नेफ्रॉन्स निकाल रहे हैं, एक रिम ऑफ टिश्यू जो कि आपके ख्याल में नॉर्मल रिम ऑफ टिश्यू है उसको साफ निकाल लें. वरना तो हम कहते हैं ना कि लंपेक्टमी है, तो लेकिन हम इसको लंपेक्टमी का वर्ड यूज नहीं करते, हम कहते हैं हमने पार्शियल नेफ्रेक्टमी की है. जैसे बास्टम सिस के लिए आप लोग लिख देते हैं कि पार्शियल नेफ्रेक्टमी, दैट इज नॉट पार्शियल नेफ्रेक्टमी. उसमें आप कोई रेम ऑफ टिश्यूज आप नहीं निकालते, आप सिर्फ सिस को एक्साइज करते हैं, मर्सेप्लाइज करते हैं. तो आपने इसको किया और एंडोफिटिक कंपोनेंट ज्यादा था, आप पेल्विक एलिसियल सिस्टम में पहुंच गए. एक तो जैसे इन्होंने बताया कि अगर आपको डाउट है तो यू शुड क्लैम्प द यूरेटर फॉर अ व्हाइल एंड सी इज देयर एनी लीक और नॉट. और अगर डाउट नहीं है, ऑब्वियस नजर आ रहा है, तो अंडर विजन पेल्विक एलिसियल रिपेयर करना मुश्किल नहीं होता. जो कुछ इन्होंने बताया है ऐसा हमने बहुत कम देखा है. Usually our practice is not like this कि complete mobilization, vascular control, slash of
Ice.
Sorry.
We are usually doing it on a zero ischemia.
अच्छा, जैसे जीरो इस्कीमिया में करते तो इसका मतलब हो गया कि यस वी शुड कंट्रोल द मेजर वेसल्स, बट वी कैन परफॉर्म द सेम थिंग अंडर जीरो इस्कीमिया. And both has its merits and demerits, or benefits or hazards. The benefit of this thing is that there is less chances of bleeding, so there is less chances of transfusion, and there are a lot of hazards of blood transfusion. Good chance with the avascular plane is that you are able to see your planes very nicely. You have good time to resect all that thing. In case of any visible artery, you may repair that thing at the same time. But what we used to do, we used to mobilize the artery and vein, and both of them are under our vision. Sometimes we take loop around them, but we never apply clamps. And we think we are able to perform, and we used to perform a lot of partial nephrectomy at zero ischemia. The benefit there is less chances of ischemic damage to the nephrons that are already been compromised if the patient is diabetic or hypertensive. But the bad thing is there is more bleeding. So if you review our previous cases of partial nephrectomy and see the amount of blood transfused during that, so then you might see we transfuse more in case of a partial nephrectomy. Second thing is because there is significant bleeding, so at times we may miss the rim. Sometimes we move close to the tumor and there is a more chances of positive margin, or sometimes because of bleeding we go away from that margin and we took excessive tissue that we may reduce if we have an avascular plane. So, but our results is that the outcome is almost same, but it is our results.
Any other point to discuss? Yes, Vikalpa?
Sorry? Renal score.
High nephrometry score. Yes, it depends from patient to patient. It depends from the condition, depends from where the tumor is located. So the renal or nephrometry score is basically based upon what we see in the CT scan and what will be our intended plan. But the definitive plan is definitely made on table. So obviously the renal score, we can proceed for partial nephrectomy in the case, but sometimes decision can be changed on table as well. Okay, it's just our a preparation, pre-op preparation to prepare patients for both choices.
रेनाल के इस नेफ्रोमेट्री के ऑब्जेक्टिव्स क्या होते हैं? आजकल it's like a fashion in any exam. Nephrometry, doctor, what is nephrometry? The name any nephrometry. And the nephrometry score is for a stone or for all that thing, for everything. तो objectives क्या होते हैं इसके? तो आउटकम असेसमेंट के लिए ये इंडिकेशन असेस करने के लिए
Yes, not for the risk stratification, but for the on table.
आपको जवाब मिला कि इट इज नॉट to make a diagnosis or to make a plan, either partial nephrectomy or a total nephrectomy or a lumpectomy or cryoablation or what. It is a nephrometry. It is a scoring system to assess the outcome. जैसे PCNL के लिए भी किया जाता है. इसका मकसद ये नहीं होता कि हमारे पास इंडिकेशन और PCNL को डिफाइन करें. PCNL की इंडिकेशन है, अब उसका आउटकम क्या होगा? हम पेशेंट को काउंसल कर रहे हैं, हम उसको कैसे बताएंगे कि भाई आपका स्टोन फ्री हो जाएगा कि नहीं होगा, किडनी फंक्शन में कितना लॉस होगा, रेसिडुअल के कितने चांसेस हैं, ब्लीडिंग के कितने चांसेस हैं. इसी तरह से इसमें तो रेनाल के ऑब्जेक्टिव इंडिकेशन ऑफ सर्जरी और डू और नॉट टू डू नहीं है, बल्कि असेसमेंट ऑफ आउटकम और चांसेस ऑफ कॉम्प्लिकेशन है.
Yes.
गुड.
So again, after excising the tumor site, we can also look for the residual tumor by the perioperative ultrasound. And after that, we are going to close the defect with the help of the 5 cm bolsters, fibrin glue, or the perinephric fat. And while doing the closure, you should have asked for the assistance to have the close approximation of these edges of the kidney. And once the defect has been closed, unclamp the renal artery, look for the bleeding, hemostasis should be secured, leave a closed suction drain over there, and a Foley drainage should be there, and the wound should be closed. So these are the possible complications that anyone can encounter after the partial nephrectomy, that are the urinary leak and the fistula, post-operative bleeding, and the renal insufficiency.
अभी डॉक्टर साहब ने जिक्र किया कि हम ऑन टेबल अल्ट्रासाउंड करते हैं और उसकी कुछ उन्होंने इंडिकेशन बताई. वास्तव में हम मार्जिन्स एसेस करने के लिए करते हैं, रिम निकालने के लिए करते हैं. लेकिन आजकल ये मैडम बैठी हुई है, कुछ तो ये भी है ना कि अब सब ओपन नहीं होता, लैप्रोस्कोपिक हो रहा है, रोबोटिक आर्म यूज कर रहे हैं, तो उसमें ये अल्ट्रासाउंड वाले ऑप्शन मौजूद होता है. फुरखानी कैसे करेंगे अल्ट्रासाउंड? तो वो तो पेट बंद है भाई, हमें तो पेट खुला हुआ चाहिए. वेरी गुड, एक्सलेंट. तो एंडो ट्रांसड्यूसर्स होते हैं या पेंसिल ट्रांसड्यूसर्स होते हैं जो कि पोर्ट से चले जाते हैंगे, और आप इवन अ क्लोज सिस्टम में भी अल्ट्रासाउंड कर सकते हैं. एंड आजकल तो फॉर ऑल रोबोटिक पार्शियल सर्जरीज ये तो एक स्टैंडर्ड ऑफ केयर हो गया है कि यू शुड गो फॉर, इवन कुछ सेंटर्स यहाँ तक तो कहते हैं कि यू मे स्किप द मार्जिन बायोप्सीज बट डोंट स्किप on table ultrasound to assess the proper margin, and because the object of ultrasound is to save maximum nephrons.
Yes, Mali.
So urinary leak and fistula. So a little bit about the urinary leak. Whenever the collecting system has been entered, there is a possibility exists for the urinary leak. So most of the urinary leaks occur during the first 1 to 2 weeks, and consider having this urinary leak. One should place the drain or left the drain for 7 to 10 days after the partial nephrectomy was done. And urinary leak, if there's a persistent urinary leak occurs, then we can perform the RPG, and RPG can also tell us about if there's any ureteral obstruction is there. And remember the management for the urinary leak, 3 tubes should be there. One is the perinephric drain, the other one is double J ureteral stent, and the third one is the Foley drainage. And the next complication is a post-operative bleeding. So if there is a post-operative bleeding, but the patient is hemodynamically stable and there is a drain is already over there in the patient's abdomen.
Sorry,
जी.
इनमें से फोली, ड्रेन एंड जेजे जैसे कौन सी चीज है जो लीक को प्रिवेंट कर सकती है?
जी जी.
माइट बी क्वारी, माइट बी, वो भी अगर उस जगह पे प्रॉपर प्लेस हुआ हो और पेटेंट हो और अच्छी क्वालिटी का हो, नहीं कोई भी चीज लीक प्रिवेंट नहीं करती, जो कुछ लीक है उसको बाहर ले आएगी। तो जेजे का ल्यूमेन क्या होता है?
Sir,
आप 6
1 to
फ्रेंच का डालते हैं, 6 फ्रेंच का मतलब है
yes, 7.
2 मिलीमीटर। आप कोई 10 मिलीमीटर की चीज नहीं डाल सकते, कोई 8 मिलीमीटर की चीज नहीं डाल सकते। Why not nephrostomy? The best thing is to control leak is good channel nephrostomy. Whenever there is an pericardial system open होता है, there is a chance of leak, place a nephrostomy. JJ, nowadays, what the JJ we used to use, we are not using spokes and parts JJ that has a half-life of 6 to 8 months and a good quality, never been interested easily. जो हम JJ यूज कर रहे हैं उसकी half-life 3 से 4 हफ्ते होती है, और हमने ये अपने सेटअप में देखा है कि many of the time we used to we on keep changing JJ 1 time 2 time, sometime वो encrusted हो जाता है, sometime वो infected हो जाता है. As compared to that, if you place just 12 Foley or a 14 Foley, that helps you a lot.
So for the post-operative bleeding, if the drain is there after the partial nephrectomy, then and also if the patient is hemodynamically stable, then the management protocol should be bed rest, repeated blood count monitoring, hydration, and the close observation. But if the HB transfusion requirement becomes, the PCV transfusion requirement becomes greater, like greater than 2 pint PCV per day increases, then it considers as a significant bleeding, and then one should consider for the radiological angioembolization. And if in case of the serious life-threatening bleeding, then the complete renal angioinfarction or the nephrectomy should be considered. So renal insufficiency can also be encountered after the partial nephrectomy, and it happens in some of the selected cases when we are doing the partial nephrectomy in a solitary kidney, when there is pelvic ileal system obstruction, and when there is a vascular thrombosis or the vascular disruption, or when there is a drug toxicity. So in these cases we can have the renal insufficiency, but it can be transient. Less number of the patients require the temporary need of the hemodialysis. So
I have last 2 years, there were only 1 case which underwent for the hemodialysis out of 215 patients.
becomes chronic kidney disease. So just briefly going through this slide, the positive surgical margins on the histopathological specimen. Again, this slide is taken from the EAU. So positive surgical margin is encountered in about 2 to 8% of the partial nephrectomies, and basically it is taken from the different studies. So studies comparing surgical margins with different surgical approaches, open, laparoscopic, robotic, are inconclusive. Most trials showed that intraoperative frozen section analysis had no influence on the risk of the definite positive surgical margins. And a positive surgical margin status occurs more frequently in cases in which the surgery is imperative, that is for solitary kidneys and bilateral tumors, and in patients with the adverse pathological features PT2A, means advanced disease. So, and majority of the retrospective analysis reported so far indicated that positive surgical margins do not translate into a higher risk of the metastasis. On the other hand, another retrospective study of this large single institutional series showed that the positive surgical margins are an independent predictor of the survival, cancer-free survival, due to the higher incidence of the distance and the local relapses. So just
That is EUA.
yes. So I'm just Dr. Shini, बस summary of evidence बता दें.
So,
Yes, so again, we have discussed today the active surveillance partial nephrectomy, but not much about the radical nephrectomy. So these are the EUA guidelines with the level of the evidence that they mentioned. Laparoscopic radical nephrectomy has lower morbidity than the open nephrectomy with the level of evidence of 1B, that is the higher level of evidence. Short-term oncological outcomes for T1 to T2A tumors are equivalent for the laparoscopic and open radical nephrectomy 2A. Partial nephrectomy can be performed either by the open, pure laparoscopic or the robotic assisted approach based on the surgeon's expertise and his skills. With 2B, robot assisted and laparoscopic partial nephrectomy are associated with shorter length of the hospital stay and lower blood loss, as we know that these are the merits of the robotic assisted laparoscopic surgery as compared to the open one. So this again falls under the 2B evidence. Partial nephrectomy is associated with a higher percentage of the positive surgical margins compared to the radical nephrectomy. So level of evidence is 3, that is more or less in between weak. Transperitoneal and retroperitoneal laparoscopic partial nephrectomy do not differ in post-operative surgical and medical complications, positive surgical margins, and the kidney function. That is level of evidence 2A. Hospital volume for partial nephrectomy might impact on the surgical complications, warm ischemia time, and the surgical margins. Radical nephrectomy after the positive surgical margins can result in over-treatment in many of the cases. So this makes the 3 level of evidence for both. So recommendations: offer laparoscopic radical nephrectomy to patients with the T2 tumors and localized masses not treatable by partial nephrectomy. Strong rating: do not perform minimally invasive radical nephrectomy in patients with T1 tumors for whom a partial nephrectomy is feasible by any approach, including open one. Strong: do not perform minimally invasive surgery if this approach may compromise the oncological, functional, and perioperative outcomes. Again, strong rating. Intensify the follow-up in patients with a positive surgical margin, especially in upstaged PT3A patients.
आपको कोई लेवल ऑफ एविडेंस का 1 2 3 और 1 2 3 A B 4 कुछ पता है तो बताओ और किसी को कुछ पता है हाँ भाई अगर नहीं पता तो पूछा क्यों नहीं था इससे स्लाइड चेंज हो गए
So there are basically 5 level of evidence, and when we
इसके मीनिंग्स क्या है 1 अच्छा है कि 4 अच्छा है
1
तो फिर पता है ना सबको थोड़ा थोड़ी बातें तो अगर नहीं पता तो ये पढ़ कर आएंगे चीजें बहुत कॉमन है और बहुत ज्यादा सब आपने कहा लेवल ऑफ एविडेंस 1 है व्हाट इज द हाउ यू डिफाइन लेवल ऑफ एविडेंस 1 ये भी पता होना चाहिए आपको
So not only the randomized control trial, but the level of evidence in the 2 and 1 2 means that the randomized control trial, but of low type, low value, but high randomized control trial falls under the level of evidence 1. So thank you.
thank you so much. Very nice presentation, Dr. Mariam.